Hi, I'm Tamara Thomas, Editor-in-Chief for Urban Health Today. I'm speaking with Cindy Borassi, President of the Colon Cancer Foundation. She's here to talk about the new guidelines for colorectal cancer screening and the importance of getting screened. Thanks for talking with me today, Ms. Borassi.
Thanks for having me.
Well, let's get started with the first and most important question. What are the new guidelines for colorectal cancer screening?
Well, we're very excited that the new guidelines from the USPSTF are that screening begins at age 45 for Americans at average risk for colorectal cancer rather than age 50. And this means that an additional 21 million Americans can now be screened for colorectal cancer.
Can you talk about the data that led to the decision to lower the age for first colorectal cancer screening from 50 to 45?
Sure. So it is a rather complex way of analyzing data, and it actually started almost a decade ago, I have to be honest. Our organization has been looking at the data alongside epidemiologists from the American Cancer Society, going back, again, almost a decade. We have actually been hosting a summit called the Early Age Onset Colorectal Cancer Summit. This was actually our 7th summit in May. And we've started seeing the trend of younger and younger Americans showing up with the disease about 10 years ago. And we use what's called the CRC registry, housed by the National Cancer Institute. And then we also use something called CISNET. And so researchers at the American Cancer Society actually started looking at that data and changed their guidelines about 3 years ago as a result of a summit that we held with them. We were very excited, but the USPSTF Preventative Task Force did not change their guidelines, as you know, until this year. And that's what most insurers go by. The payers don't really go by, don't change their rules and their payments until USPSTF changes their guidelines. That's what's so exciting about the change this year. And they use the same data to do their modeling and statistics, and that's what changes their guidelines. The other thing that they take into consideration is, of course, the ability for our healthcare system to handle the onloading of an additional 21 million adults to get screened. Because you have to remember that right now, nearly a third of the Americans over the age of 50 aren't already getting screened. So you throw in another 21 million Americans 45 and older, that's a huge population to get screened. That was another consideration for them.
So colorectal cancer patients are being diagnosed younger, as you pointed out. I read that the American College of Gastroenterology made the recommendations in 2005 and then in 2008 again to lower the screening age because of the increased risk they were seeing. So it's curious that the USPSTF didn't take that up until so many years later. But better late than never. So in go ahead. Sorry.
No, I was going to say their cycle for changing their guidelines is frustratingly slow. It was very frustrating for us, all of the organizations in the colorectal cancer community, to have to watch and wait for this, as we watch so many young patients die. To be quite honest with you, we actually see patients die, sometimes multiple patients that we know a week, every day. And we get to know these patients, and it's heart-wrenching. And, we know the parents, we actually know parents that lose patients, their sons and daughters as young now as 18 and 16. So it is really frustrating to wait for these lines to take place. And then it's even frustrating now that this has taken place, the insurers aren't responsible for starting the payments until 2023. So yes, so
Really?
yes. So now it's, now it's us putting the pressure on the insurers to get on the ball and start the payments as soon as possible and not wait until the last possible moment to implement the payments for these screenings,
Is that every
not to take their
state, or
time.
is that across?
That's you. That's universal. Yes. So
Really?
now it's up to every state and it's up to every insurer, so,
Right.
right.
I'm curious with this data. The National Cancer Institute is saying that these numbers are going to double by 2030. With that data in mind, why not age 40?
So this is an equally frustrating rationale. So what they look at is life years earned and life years lost, and the net result, and what we would get if we started screening earlier. And that's really the rationale. And it's quite frustrating as an individual to think that they're looking at, global public health on that scale. But that's honestly one of the largest considerations for it. But I want you to keep in mind that the current guidelines still recommend, even if we're not starting screening at age 40, the current guidelines do recommend that we be diagnosing based on symptoms. And those are current guidelines. And that's always been the case. So even if, we were still starting screening at age 50 before, doctors, primary care physicians still should have been looking for symptoms and signs for decades, and they weren't necessarily doing that. And that's something that we have to be doing a much better job of, as you know.
I read an interesting story recently in one of the health blogs about a young lady who was 27 years old. And sorry, this is a slightly off topic, but it is,
That's okay.
part of what you're talking about. And she went to the gastroenterologist because she was having pain. She had trouble eating, and she lost a significant amount of weight without trying. And I guess because of her age and because of her weight, the doctor dismissed her concerns and said, "Oh, it's great that you've lost all this weight. Nothing to worry about. I'm not going to do any screening. You're young. You've lost all this weight. It's a blessing that you can't eat solid food." And it turned out she got a second opinion, and it turned out that she had a humongous tumor, and she had stage 3 cancer, which thankfully she got treated for. The tumor was removed. And she's on the mend now. But that, I wonder if that's something that young people should be worried about with early onset. The youth being dismissed, like, "Oh, you're young and healthy." I wonder if that's what happened to Chadwick Boseman. But in any event, so what do you think is driving this trend of younger and younger people turning up with cancer?
So that's actually one of the most important things that we look at every year with our summit, and not just the day of the summit, but all year round. We are looking into research as to why this is happening. And, just a startling statistic for you. So anyone born after the 1990s is 2 times more likely to be diagnosed with colorectal cancer and 4 times more likely to be diagnosed with rectal cancer, which is startling. It's a startling statistic for the public health community. And even, someone who's not in the public health realm, those are startling numbers. And then, of course, the other startling statistic I don't like to quote, but I have to quote, is that the most rapidly rising rates are in between the ages of 20 and 29. And again, those are more pronounced in the rectal side of things. And those are just devastating statistics. But we don't know yet. We have some inklings. They are spending a lot of time looking at That's the food we eat. So is it changes in what we eat? Is it genetically modified foods which are affecting the gut and the microbiome? Is it the environment? We're looking very closely at epigenetic changes, which may be, driving. So is it a large global epigenetic change in our systems? Or are these young people genetically predisposed to develop cancer, and then something in the environment triggers their genetics younger than, say, someone who wouldn't get this until they were in their 60s? Because it is more likely to be in the past, you were more likely to be diagnosed with colon cancer in your 60s and 70s. Right. So we don't know if these colon cancers, when you diagnose when you're young, it could be that it's an entirely new disease. We just don't know yet. We do know that some of these can be much more aggressive tumors and lesions than in those that are diagnosed later on. Because the other very sad thing is that, you were referencing the 27-year-old. Most of these cases are diagnosed at a very late stage, and we know what those prognoses are. That's a much poorer prognosis because of the late stage diagnosis, and a higher death rate. And it's because they are often dismissed because they're young. And so we have to change that. We really do have to change the whole conversation around this, that you can get colon cancer at any age, and you can have the symptoms at any age for colon cancer.
So I know ASCO came out a couple of years ago saying that all alcohol, well, they've changed it over the years, but they've upgraded it to say that all alcohol consumption is carcinogenic. So, that might be another factor. I hope that researchers are looking at. I know that the research community is kind of grasping right now, like, what is going on? What is creating this tidal wave?
Right.
Can you talk about the factors driving the rise in disparity in colorectal cancer? For example, I was just reading about colorectal cancer hotspots throughout the country. Places where doctors are finding clusters of people turning up with colorectal cancer diagnoses.
So again, it could be, there are multiple factors here. We actually do find familial links in hotspots with familial links. They're called gastrointestinal hereditary syndromes, where they go back in generations and they find something like Lynch syndrome. It's similar to the BRCA gene on the colorectal cancer side. So that's one possibility. Two is health equities and disparities, where you've got a very low income, economically distressed community, where there's low access to care, or they're in a rural setting where it's difficult to get to screening. For example, let's say they're in a very rural area and there's hardly any, there isn't screening there.
Right.
There's the language barrier, for example. There's education around the food we eat. Obesity is a factor. We do see very different rates of diagnosis, for example, diagnosis and mortality in the Black community, as well as one very alarming statistic is in the American Indian and Alaska Native populations. So in the Black community, we see 20% higher diagnosis, and we see a 40% higher mortality rate, unfortunately. And then we see 2 times that, double that, in the American Indian and Native Alaskan population. And the public health and epidemiologists are digging into both of those populations, and all of that has to be addressed immediately. And actually, we're as a foundation working, for example, here in New York City with one of the largest health systems in the country to directly address that issue.
According to the Journal of Clinical Gastroenterology, lack of screening seems to also be high up there in terms of disparity rates for white people versus people of color.
It could be lack of screening. It could be, so there is also demonstrated cultural barriers to, not wanting to undergo a colonoscopy, for example. But one thing that has been highlighted in the current guidelines, and even, for example, here in New York City, we're stressing, and around New York City, there are multiple options for getting screened other than colonoscopy. And especially now that we've been so hard hit by COVID and screening basically came to a screeching halt, it's had a devastating effect on colonoscopy. And so there are multiple mechanisms for getting screened at home, as a matter of fact. So you can start the process with an at-home FIT test. There's CT colonography. You're still doing the prep, but you're not undergoing a colonoscopy. So they're just as effective. The colonoscopy is still the gold standard, because if you're going in there and they find something, they can take care of it while they're in there. But there is a way for someone to get started with the screening process. And then, of course, if they find something, they would have to undergo the colonoscopy and take care of it.
Well, let's stay with that for a second. So there's colonoscopy. Mm-hmm. There's the virtual colonoscopy, which I actually just had one of those 2 weeks ago.
Okay.
But my doctor didn't even know about virtual colonoscopy. I guess he never heard of it. He actually, looked it up on his computer while I was there explaining.
Oh boy.
Yeah. So there's colonoscopy. There's virtual colonoscopy. There's also, what is it called? Is it called DNA, stool DNA, right?
Right. There's stool DNA, which the big name is Cologuard. We work very closely with the manufacturer, Exact Sciences, and most people know it by the dancing white box on the TV screen. Yeah. And you can actually get that shipped right to your home.
I guess I'm wondering why are providers not having conversations about these alternatives? Because there is a lot of fear sometimes, in terms of the lack of screening. There is that fear of for a man, it might be emasculating to undergo the procedure. Some people may be concerned about the anesthesia, being unconscious. There's also a fear of, take your pick. I have the BRCA2 mutation, which puts me at high risk for colorectal cancer, as well as breast cancer and a host of other cancers. So this is something that's kind of near and dear to me. So why is it that doctors are not having these conversations with patients and saying, hey, look, because with breast cancer, there's so much conversation. The information is just abundant. And I don't see that in the colorectal cancer space. And given the almost epidemic, numbers of people, coming, 21 million is nothing to sneeze at. Why aren't doctors doing a better job of educating people about their alternatives for some form of screening? Any form of approved screening?
Your guess is as good as mine. And I tend to be, people tend to look at me kind of sideways in this space, because I think it's time to get a little loud, almost like the breast cancer advocates got loud in this space like 20 years ago. It was probably about 2 decades ago, maybe, I don't know if it was that long ago, but I'd have to go back and look at when they got
that sounds about right. 20,
or even even the AIDS advocates, HIV AIDS. 30 years. I'm going to equate it to that, where they started demanding that we talk about this. It didn't have the same cultural repercussions, I guess, in the AIDS, HIV
Right, right.
environment. But you're right. So I see breast cancer being discussed on the soccer fields at the age of 6. So, and little boys. So, I mean, it's the whole universe is talking about it. And so I think, and we talk about this in the colon cancer space. It's like we're talking about it in an echo chamber. It's just we talk amongst ourselves about it.
Okay.
And so we have to get a little bit of activism going here, if that's the right word. But you're right, we have to be talking about all the alternatives. One question came to my mind. Did your OBGYN, when you were diagnosed with BRCA, talk to you about getting a colonoscopy?
He did not.
So why not?
Exactly.
Why not? Why wouldn't he, if you were more susceptible to colon cancer, why wouldn't he have done that? Why wouldn't any woman who was diagnosed with BRCA be told about that? And why wouldn't and we're already talking to the ACOG, which is American College of OBGYNs here in the New York City area, about them getting involved because they know how to handle ovarian, cervical, breast cancer. So why not get them involved in talking about colon cancer? They're a natural fit. They see women from a very young age, their entire lives. It's finding men, but.
Yeah. Who spoke to me about it was actually my breast oncologist. So then is it incumbent upon patients then, what's the approach that we take in terms of getting the word out? Do we educate patients more, or should providers be the ones to be educated so that they in turn educate the patients?
Well, I think it's two-pronged. I think we need to go, system down for the providers. That's why I'm very excited to be talking to you today with your connection into the provider space.
Yes.
I think educating the providers is critical on as broad a scale and as active a scale as possible and as quickly as possible, because the epidemic, public health will not call it an epidemic. I'll tell you that right now. They are loath to call it an epidemic. That is out of their mouths. They will not do that.
But you and I agree that it is. I mean,
yes, yes. But they will not call it that. When I see 18, 16, 14-year-olds die of colon cancer, that's heart-wrenching. So something has to be done. For example, in the cervical world, they were really successful in arming the patients. And then go back to HIV and breast cancer. They were really successful at arming the patients and activating them.
Right.
And with information to demand awareness, and turn them into their own advocates and demand change, within the primary care space. And when I talk about primary care, I mean any provider who's touching a patient before they could be diagnosed. So I'm even going back to, for example, your pediatrician to your primary care provider, because, for example, if you have the BRCA gene or you have the Lynch mutation, that's going to change when your child is starting to get screened. And it could start as early as you're going to have that conversation when they're young,
right?
Starting when they're a child. This gets into bioethics, but is it 16, 17, 18, 19, 20? It could be that young. And we're thinking about, some of these mutations are showing up and they're skipping a generation, and we don't know why that's happening, or it's just showing up out of the blue. They have these genetic mutations and it hasn't been in any of their family members that they know of. So why is that going on? No one in the space knows the answer yet. But that's going to have an impact now on their children. And that's really important. The family history is another really important way for us to prevent this disease, which isn't being done by the primary care space either. We know for a fact that they aren't taking family histories, and they aren't, for example, when someone's diagnosed, they aren't explaining how important it is for them to now tell their entire family and then do what's called cascade testing and test the entire family for that mutation and their children, because that would change their risk.
I think about cervical cancer, for example, and HPV in the link. And I wonder, do you think, and this might be slightly controversial to ask you, but we're talking about it, so let's talk about it. Do you think that if there were pharmaceuticals directly related to the colorectal cancer, that there would be a bigger push for education? I'm wondering.
Oh, like if there was a
Right, like if
cure,
there were
like,
a drug, would
yeah.
there be more research and more dollars and more public awareness of, the disease?
I wouldn't say no. I,
Just
I
a
would,
thought, just a,
yeah,
not an accusation, just a thought.
no, I would, yeah, I wouldn't say no. And I mean, that's another thing to look at. I mean, I get so frustrated, to be honest with you. I go into my kids are, my daughter just graduated high school. I have a 16-year-old son, but you go into every pediatrician's office and you see, do you want your kid to have cancer? Of course I don't. But why don't we talk about every type of cancer and not just HPV? Why didn't we take the opportunity to address every single type of cancer, including colon cancer? I mean, I think it's great. They've done a great job. They still have a
They've
long
done
way
a
to go.
fantastic job, yes. So I have to tell you that I had a conversation with my neighbor a couple of weeks ago. Well, about 3 or 4 weeks ago. And at the time I spoke to her, she had just had resection surgery done because she was diagnosed with colorectal cancer. And her colonoscopy was negative. Okay. So years 1 through 4, because she's high risk, so she's every 5 years instead of every 10 years. Between years, say the screening was year 0, between years 1 and 4, she developed symptoms, was diagnosed, and had the surgery. She was not due for her next screening until 2022. So the question then becomes, why is there this long time between, why is that, what's the rationale for the length of time between screenings?
I mean, I'm sure, so it goes back to evidence-based studies that they've done over decades, and looking at tumors and looking at, symptoms and looking at cancer registries. So this goes back decades, and developing the guidelines. That doesn't make any less frustrating. So that's what this is all based on. One of the things that has come out, and I'm sorry that this wasn't used, but they're actually developing blood tests that can detect cancer in between. So, for example, it might have caught the occurrence or recurrence of cancer early or earlier for high-risk individuals, which is a really exciting new development in the space. So we actually work with a company one of the companies it's very frustrating. The blood tests to detect, this is another exciting development, but they're trying to get approval through the FDA because they didn't make it into the guidelines this go around. But if you can imagine how exciting a blood test to test for cancer could be, because everyone's used to having their finger pricked or their toe or their heel pricked from the time they're born. But that would have been something that would have been simple to test her for. Now, why, I wanted to unpack that a little bit, but why is she high risk? If you don't mind my asking.
Her mother died of colorectal cancer. They thought it was hemorrhoids the whole time.
Someone would have to look at her case and see, her specific situation and the guidelines and see, was that followed correctly? I don't know. I'm not going to comment.
Guidelines is every 5 years if you're high risk, sort of. I mean, they don't really have a,
Right.
yeah, the American Cancer, they
And
don't,
then, but
but,
yeah, and then there are,
but
and
that's
then
sort of
there's,
what doctors, like, when you speak to doctors, they say 5 years. You know, my doctor even says 5 years.
right. But then there's family history to take
Right.
into account. Then there's symptoms to take into account.
Right.
So,
And then what if she
yeah,
didn't have symptoms? That's so scary. If she didn't have symptoms, when they caught it, she was stage 0 to 1.
right, right,
And they got it out and she's doing the chemo fine. But what if she didn't have any symptoms?
right.
My God,
Well,
that,
and that's the problem with this.
yeah,
Yeah. That's the problem with this, is that we often call it the silent killer, and why we stress, you know, earlier conversations leading to on-time screening, because it often doesn't, once you have the symptoms, it can be too late,
yeah.
because it takes a normal tumor takes a good 10 years to develop.
Oh,
So you starting with the polyp, and you may not even feel it.
right.
So once you get to the bleeding stage, that's where you're talking later stage,
Right.
colon cancer. So that's why the preventative screening is the most beneficial, because they can go in and they can take care of it,
But she had the screening and then she,
I know.
yeah,
So maybe, again, this goes back to, we don't know if these are more aggressive types of tumors. That's where it would be really important for, if she hasn't been tested for genetically, and a genetic syndrome,
mhm,
that would be important, because that's what they're documenting.
mhm.
They're compiling all of this data, and it's a really exciting field. This is where I get excited. One of the speakers at our summit is talking about artificial intelligence and bioinformatics, and they're trying to accumulate hundreds of thousands of cases, because they can't really dig in until they kind of hit a sweet spot, which is over 100,000 cases. This is at Memorial Sloan. But once they get there, then they can start looking to see what are the common threads. Like you were talking about those hot spots.
Yes.
Then they can start looking at those hot spots and really figuring out what's going on. What's driving, because they're pulling in more information than just the tumor. They're pulling in personal information, they're pulling in history, they're pulling in zip codes and neighborhood information. So that's a really exciting, new field. And I think that's where they're gonna it's hard because it's not this year. They're not going to find the answer this year, but I would say within 5 to 10 years, they're going to find some answers, really good answers.
So if we could just circle back for a second to the stool DNA, the Cologuard, for example. How does one get their hands on? Do you need a prescription for it? How does someone get their hands on it? Say they want to take their health into their own hands, and 5 years, 4 years is not enough time. It's too long rather to wait for the next screening. You just want to know every year for
Right.
certain.
So they can actually go, they can go to their primary provider and request the test if they're 45 and older. And or they could go to Cologuard. I believe it's cologuard.org. And they can actually go through Cologuard, and they will put them in touch with a provider, if I'm not mistaken. They actually have telehealth support in multiple languages, which is awesome. And so they have two ways of doing that. And I'm almost possible, because we actually have a partnership with Walgreens. We have a site called letsgetscreened.org, and you can actually get to it on that page. You can actually get to the Walgreens kind of health site, and there, and it will actually take you to the ability to get to the ability to order not just the Cologuard test, but different fit tests. So not just the ctDNA test, but they offer over-the-counter fit tests. So there's a test called BioAmerica, which is actually just a tablet that you drop in your toilet, and it's kind of an immediate result. So there's multiple over-the-counter tests that you can order even on Amazon.
Really?
Really, I know, it's great, it's incredible. So you can order them on Amazon. You can order them. There's a test called Everlywell. We actually did a campaign. We like to call ourselves a little bit disruptive in this space. So we did a campaign earlier this year in Colorectal Cancer Awareness Month called the Give a Crap Challenge. And we we partnered with a company called Squatty Potty. I don't know if you're familiar with them.
I'm familiar. I actually have.
You have a Squatty Potty.
Yeah.
Yeah. So we partnered with Squatty Potty, and we partnered with Duclaw Brewery. Even though alcohol is carcinogenic, there are still people that drink beer. So for the beer lovers out there, Duclaw Brewery brewed a special beer for us, and we also gave away a Squatty Potty, a glittery beer, and a stool test from Everlywell for a $75 donation. And it's a fit test that you can do at home. And they actually can get the results right on their cell phone.
Oh, wow. Okay.
Yeah. And they actually also have support. So there's multiple ways to do this at home. Mm-hmm. And then there's also, if they wanted to talk to their provider. The other thing I want to stress too, if they're having symptoms like a change in bowel movements, any blood in your stool is not normal. Do not let a doctor tell you that it's normal. And even if they say, oh, it's just hemorrhoids, if they do not do an exam, they don't know. So go on, find another provider who will do an exam.
Or insist that your provider do the exam.
Do the exam, yeah. Right.
Yeah.
Right. Because they cannot know until they do the exam. So don't let them tell you blood in the stool is not normal. It's also, for example, if you go in and you do your annual blood work and you're severely anemic, especially men, mm-hmm. That's another red flag. A big change in weight. So it's either losing a lot of weight, like you were talking about the 27-year-old, or even gaining a lot of weight all of a sudden, mm-hmm. is a big red flag. So any of those symptoms are something to be on the lookout for. I've even heard of, severe back pain, unexplained back pain, not necessarily from working in the garden or working out or something like that.
Right, right.
So
what's your thought on virtual colonoscopy, by the way?
It's an absolutely acceptable, it's in the guidelines. We actually work very closely with, we have one of the chairs of the American College of Radiology on our medical advisory council. And she actually she's the chair of radiology at Montefiore. And they actually use it as a perfectly acceptable swap for colonoscopy. Mm-hmm. Yeah. Especially for those that may be at high risk for internal bleeding, if they're on blood thinners, or if they're older, or if they just don't want a colonoscopy. And especially given right now where we're so far behind on colonoscopy and there's a backlog due to COVID, they're using CT colonography. So there's multiple reasons for it.
Well, can I tell you, I had the conversation with my gastroenterologist about doing the virtual colonoscopy, and she basically told me, like, find another doctor if you're not going to do regular colonoscopy. So I was just wondering, what the conversation was about that procedure, particularly among gastroenterologists. And I know you're not a gastroenterologist, but you're close to the ground. So I'm just curious what the feeling was about that procedure.
Well, it is a little political. Well, it might be a lot political, because for a long time, the GIs were firmly entrenched in this space. You know, they had the monopoly on this.
Right.
And so this was their turf. And, you know, to give up the turf to the radiologist basically is what they're having to do. But, or to give up the space to the blood tests or to CT colonography, the ctDNA test, Cologuard, you know, is how they're looking at it. But, you know, for those of us on the outside looking in, you know, the foundations, the blood test, ctDNA, FIT test, radiologist, we're looking at it as you have not accomplished the goal. You haven't screened. There's still a third of the Americans above the age of 50. There's now 21 million more Americans to get screened. And all of the young Americans who are now getting the disease, you think you can accomplish by yourself?
Right.
You know, so clearly we need all hands on deck.
I mean, I think sounds like to me. Yeah.
Mm-hmm. Right. And so that's another, you know, change in the conversation. And we actually, you know, we've had conversations we were very close with the American College of Radiology before COVID hit and launching this big, you know, conversation campaign about trying to change that conversation. They just kind of haven't wrapped their heads. They're not a big they don't have a big marketing department, if that makes any sense.
Okay.
But I think they need to, because it's in the guidelines as an acceptable form of screening.
Well, something interesting happened a few years ago. So at Johns Hopkins Hospital, a doctor was doing a study. I forgot the doctor's name, but he was doing a study to see if nurse practitioners would be just as effective. Tell me if you're familiar with this one. Would be just as effective at performing colonoscopy. And the gastroenterology community jumped all over him. Oh, this was racist. And how do you do that? I don't think many of them even knew that he was Black. But
right, I read that. So I'm curious, what do you think of that? Because the guy said, I think it came out that most of them didn't know he was Black.
Yeah, didn't know, right. They had no idea that he was a Caribbean Black man.
Right.
They accused him of being racist for trying to get as many. I didn't think it was racist at all. I thought it made perfect sense as a patient. I can't tell you how many times I couldn't get an appointment with my actual doctor and I ended up seeing a PA or an NP because it was just faster. You know, I didn't have anything that was necessarily bothering me that I needed to specifically see the doctor about. To me, they're just as competent. I didn't see a problem with it, and I was very disappointed in that sort of cancel culture space that they tried to put them in. Now Johns Hopkins has distanced themselves from it, and they're not standing behind it. But I'm sure at the time they thought, hey, this is a great idea. Well, I think the other thing that happened was insurance wasn't going to pay for it, right? The insurance didn't pay for it because it wasn't performed by a physician. So I think that was the other reason they backed away from it. But it's a shame. That's the other thing. There are probably people who are not necessarily opposed to having the procedure, but the wait is so long sometimes. And it's like, I've got to get on with life, you know, like, you know, I can't wait 6 weeks, or I don't know what I'll be doing in 6 weeks, or I've got vacation in 6 weeks. Yeah, it's just too long sometimes.
Yeah. Well, I know of a situation. So here in New York City, there are a number of endoscopy centers who actually they volunteer, the GIs volunteer to do colonoscopies for, you know, distressed communities and or uninsured patients. And so I was discussing this with someone out in California, a GI out in California, and he's like, that's a great idea, but what about the liability? And that came up as a very big concern for him about the liability. of, treating these patients. And I'm like, I didn't even think about that. But that was one of his biggest concerns about going out into a community on his own, because he would do this on his own,
Okay.
not through a center or a hospital.
Right.
So you just think about all these things in such a litigious, society that has to be on his mind. He just can't go out and do a service like this,
Right.
which is so sad. So that was kind of where we left off, that he had to investigate all of that before he could just go do it. But you're right. I mean, the thing is we're also in such a shortage for medical personnel, PAs, nurses. I mean,
particularly now after, the pandemic, where so many people have just, left the field or retired out or died or decided to move to, some other area of medicine where it's not as traumatic. And they're not, the AMA is still only graduating X amount of physicians a year. I understand that last year they just graduated some up just to fill the need, just graduated them early. Just to fill the need, but how long are they going to continue to do that? And then the other issue is a shortage of providers of color, which I think would make a huge difference in the disparity discussion as well. It's a complex situation. By the way, what's the name of the blood test? It's not the CA19, is it?
No. Oh, I forget the numbers off the top of my head. I'll get it to you though.
Thank you. Yeah. I want to add that information to the link.
Yeah.
Ms. Borassi, this was a fantastic conversation. Is there anything else that you want to add before I let you get on with your day?
No, this is, yes, likewise. It's been a great conversation. It's a pleasure meeting you. And I'd love to stay in touch and talk about
absolutely
what we might do together. Like you said, what could we do to get providers talking about this? Yes. That kind of thing. So let me know once you get through all of this.
Absolutely. Because, people are dying. People are getting sick. What can we do on the front end of this? Because when you get to the end, it's too late.
Yeah, right.
So, something has to happen on the front end of this conversation. And I'm not sure what that is, but, I'd like to work with you definitely to try to figure out, what we can do outreach wise to get more of the word out.
Yeah, that would be great. That would be wonderful.
Right. Thank you so much for your time. And, we will be in touch. And, have a great day. Thank you.
You too. All right. Bye-bye.
Bye.